to have invited Dr. Basil Shikely from USA to share with us his topic, cracks and vertical root fractures in English. Dr. Basil Shikely earned his first dental degree from Baghdad University School of Dentistry almost 15 years ago. And he earned his second degree in dentistry from University of the Pacific School of Dentistry in California, where he received numerous awards. He completed his endodontic postgraduate training at Texas A&M Baylor College of Dentistry. Dr. Shikely currently holds a full-time private practice position in the north suburbs of Dallas at Essential Endodontics in Denton. He enjoys staying in teeth and being a valuable member of his colleagues and their dental teams. Now, before starting our live, I would like to take this opportunity to invite you to watch a short video of COXO Endomotor C-Smart 1 pilot, which is a very cost-effective and are sold well all over the world. By the way, every time during our COXO free public webinar, we prepare a certificate for those who join our course, which would be part of the qualification for your career. Now let me introduce how to get our certificate. Now please see. There are two steps. First one, the first step okay. The first step. Follow and like our COXO page. The second step, leave a comment or questions below the live video. At the end of the live, we will share the forum link to the comment below the live video. Please open the link and fill the form and submit to apply for the certificate. Once the above three steps are all done, in 5 days, you will receive PDF certificate in your email. Please note, this form application can be filled only once and will be available for only 5 hours after the lecture. 5 hours later, the application channel will be closed. After that time, we will not accept any application anymore. Please fill out the form as soon as possible after webinar. Second, the form cannot be modified. Please make sure the information you left is correct. This is what the certificate looks like. Okay. In the end, I want to remind you that in the webinar, we prepare two prizes. One is the best question prize. Please leave your questions below the live video. Dr. Basil Shikely will answer your questions and pick up the best one. The person who raised the best question will get our gift, 3 sets of our SC Pro endo files. 2. The second prize will be chosen by the lucky draw. You need to comment on the video during the live. Then you can have a chance to get our special gift. And in today's webinar, the special gift also is 3 sets of SC Pro endo files. Okay, now let me welcome Dr. Basil Shackley come in. Hello.
Hi, Bruce. How are you?
How are you, Dr. Basil? Now we'll leave the precious time for you to give the precious lecture. Now let's begin.
Absolutely. I would like to thank you and thank COXO for arranging this webinar and give me the opportunity to use the platform to reach out to our audience and talk about a very, very nice and yet challenging topic, which is cracks and vertical root fractures in the world of dentistry. Today presentation will be more, I would say, a casual presentation, mainly directed to general dentists in their helping them in their daily day-to-day practice. I'm not going to bore you with a lot of research or articles. I will give you few that I feel like they are very important for you to have. Most of the webinar or the seminar will be clinical cases based. So we'll take some cases and we'll discuss them, and we'll take a look at the diagnosis, the etiology, the outcomes of the selected modality of treatment that we chose. Please let me share my screen. I think if I go this way, let me know if you see my screen here.
Okay. Now let's start your lecture.
Okay, so can you hear me very well?
Well.
Perfect. And do you see the screen?
Have you seen?
Screen? You see the screen, Bruce?
Yes.
Perfect. So again, I'm Basil Shackley. I have a double degree, graduated from Baghdad University back in Iraq, and moved to the United States about 10 years ago. Went to California to the University of the Pacific to get my DDS degree, then moved to Texas to get my specialty in endodontics, and I attended Texas University, Texas A&M College of Dentistry here in Dallas, and I'm practicing at Essential Endodontics in the north side of Dallas, DFW area, in a city called Denton. If you're local, you'll know where I practice. The presentation or the webinar today is cracks and vertical root fractures. I always use the analogy of the windshield crack and make it easier for our patients to understand the cracks that can happen in the tooth structure. And there's a lot of similarity between the windshield crack and the cracks that happens in the tooth. One of them is the crack is very, very, very small in nature. And also, just like the windshield crack, the teeth crack can get longer and deeper, can propagate, we call it, by vibration, heavy occlusion, sudden bites on hard objects. The same thing can happen to a crack in a windshield. I grew up in a family that they are all in the engineering side. Most of them are mechanical engineer. So when I do analogies, when I give examples, most of them are actually related to cars. Yes, you can accuse me as am I a mechanic or am I an endodontist? But most of the patients will have some experience, repairing cars and having problems with cars, and they understand the nature of that. So when you give them an example of that, they will understand it better. There's a reason why I picked that specific background. It's the blurriness behind that windshield is actually very consistent with how vague the diagnosis of cracks and vertical root fractures can be. And because of that, I would like to spend more time today on pretty much decoding that topic and try to make it simple for our general dentists and our colleagues and as restorative dentists to be able to diagnose, to be able to be comfortably execute their treatment, because there's a lot of it is unknown, a lot of it is blindly diagnosis that we have to do, especially with vertical root fractures. We'll get into details soon in the presentation. So let's talk about the definition of a crack. So crack is any discontinuity in a material. Material can discontinue due to a crack, and if that discontinuity is partial, then we call it a crack. If it's complete, then we call it a fracture. That's the difference between cracks and fractures. What's the etiology? Like, why we get cracks in the coronal structure? What's the etiology and the reasons behind it? Most of those are, like, I categorize them into three major categories. One is the parafunctional habits, clenching and grinding and bruxisms. We see a lot, especially if you're an endodontist, you see cracked teeth on a daily basis. And I noticed that actually after after COVID and the stress that a lot of people had went through, cracks and vertical root fractures, it seems like it increased in number. This is anecdotal, findings from just the amount of patients that I see on a daily basis with vertical root fractures and cracks. The other etiology is biting trauma. We have, patients who like to do ice chewing or bite on hard objects. So I always tell the patients, try to kind of like, give them an idea of why I'm asking this. I said, okay, cracked teeth usually has a reason. They come because they develop because we do something that stresses the tooth. Part of it is, do you do any ice chewing? Do you bite on hard objects like pencil, pen? Do you like to bite on hard candy, for example? And the patient will say, oh, yeah, I love ice chewing, for example. And that is actually the worst thing you can do to your teeth, is bite on rocks. Ice is as hard as a rock, So you don't want to do that. And we always tell the patient, please, this is a habit. We'd like you to stop it and save your teeth and and prevent further fractures and cracks. The third etiology is accidents. Motorcycle accidents, sport accidents, biking accidents. Those can either fracture a cusp, crack a tooth, or further develop a vertical root fracture into the root structure of the tooth. So those are the three main categories that I see that I see on a daily basis related to cracks. Now, how to diagnose cracks? One of the challenging things that I see is diagnosis cracked teeth. They're very challenging for many reasons. First of all, it's very hard to see. Second, we always, try to find a cavity, a big decay in a tooth to start thinking, okay, the nerve may be damaged, the nerve may be inflamed. However, the nerve can be inflamed and damaged and lead to severe pain due to a very small crack. That crack, again, we'll go back to the analogy of the windshield crack. Just like the windshield crack collect dust in that very microscopical space, the same thing happened in a tooth where there's a crack. Bacteria start hiding in that crack, and that crack will act as a path for microbiome and bacteria to travel from the outer surface of the tooth, where it's bathed in saliva that has, bacteria in it, apparently, and drive it all the way to the nerve. The nerve will fight for the first maybe few days to few weeks, but eventually it'll get severely inflamed, and then it will become necrotic if no treatment will be rendered. So that is the progression of the disease when it comes to cracks leading to a nerve inflammation. That's why when I talk about symptoms in cracks, I always divide them into early stage symptoms and late stage symptoms. So when it comes to early stage symptoms, most of it is cold sensitivity, maybe spontaneous pain, throbbing pain, night pain, biting sensitivity, especially when the patient will say, and all of a sudden I bite on on that tooth in a certain direction, and I feel sharp, severe pain, and more like a zinc pain, very fast, but it's really, really strong and severe. That's mainly happened when the inflammation and the crack it's in early stages. After that, the progression of the disease will lead to necrosis of the nerve, of the pulp tissue, the pulp tissue inside the tooth. Now, when necrosis happens, there's no defense mechanism inside the tooth. Now, what happens is bacteria start taking over the space of pulp tissue, the pulp chamber and the canal system. And that's a perfect environment for bacteria to thrive in there, because it has the right temperature, it has the dark environment, it has nutrients, which is the remnants of the necrotic tissue, and that will develop into a periapical lesion, into an infection and maybe swelling. So now the symptoms will become, it's dull pain when I chew on that tooth, or sometimes they have no symptoms. You take a radiograph and you see, oh, this tooth has a big periapical lesion, but how come there is no large infection? Excuse me. There is no large infection, so there is no large decay. So we always get confused when we see periapical lesion and there is no decay. The case is most of the time is a cracked tooth. There's other etiology that can lead to periapical lesion with no decay, but for the sake of our discussion today, it will be mainly cracked teeth. Now, is there any radiographic evidence? The hard thing about cracks in the coronal structure, it doesn't have a lot of early signs of radiographic evidence, unless you leave that disease to progress further into the periapical lesion state. Then you start, noticing the radiolucency at the base of the apical or at the base of the apices. Clinical hints. One of the things that we talked about is the early signs of crack become sharp, but also there's another sign that can happen later in the progression of the disease, which it can be heat sensitivity. Heat sensitivity is a little different than cold sensitivity from the physiological process inside the pulp tissue. The alpha fibers, they are responsible for heat sensation, for cold sensation. However, the C fibers inside the nerve, which can survive longer in the event of necrosis, and maybe will be the last fibers to die, are the C fibers, and those are the ones responsible for heat sensitivity. That's why when you open a tooth where the patient has severe heat sensitivity or heat pain, you find that this tissue, the pulp tissue, is mostly necrotic. It's mostly gone. Maybe just a very small amount of vital tissue still left in it. So that's one thing that I wanted to highlight here. The other thing is the hint we take from the patient is like, I have, if the patient will say, most of the pain I have it is when I wake up in the morning, then we suspect cracks, because usually the patient grinds at night, and that will, aggravate the crack and aggravate the nerve inside the tooth. Let's talk about how we can diagnose cracked teeth. First thing we can use is the illumination. Illumination is you direct a stream of light source to a side of the tooth, and then you will see how clear. If you see my pointer here, let me see if my pointer is working. Yes, I see. If my pointer here, you see clear crack. That's where the discontinuation of the light happened, because there is a crack, and that crack has a different density in it, and that would not transmit light as a solid tooth structure here. Same thing you can find here. However, this technique has some limitations. So one of the limitations we have is, what if the tooth has a full coverage restoration on it, full coverage crown? Then you cannot use the illumination. The other technique that I personally really like, and I think it's, to me, even if you blindfold me and you give me a bite stick, I can find a cracked tooth if there's a cracked tooth. Biting stick or tooth sleuth is very, very powerful and very accurate. I start on a tooth that doesn't have a crack, or that we don't suspect a crack on that tooth, maybe a contralateral tooth, and then just make the patient bite down and open, bite and open, just to make them feel this is the normal feeling, that's the normal sensation. Then I'll start testing the tooth that I suspect. And I go cusp at a time, and I ask the patient to bite and release. If the patient will feel the pain on biting or releasing, then you suspect a crack on that cusp. The more there's a lot of talk about releasing pain. I personally find releasing pain is very accurate when there is a crack, but it's not. It doesn't happen all the time when there's a crack. It doesn't, that having no releasing pain doesn't mean that there is no crack. So I still suspect a crack if the patient will bite on 3 cusps and said, okay, I have no pain, and then bites on one certain cusp and the patient feels the pain. I still suspect a crack there, especially if the whole picture supports a crack in that tooth. Let's talk about a clinical case here. That's tooth number 19, preoperative radiographs. The tooth looks fine. It has a deep restoration, no periapical lesion. The CT scan also shows that there's no furcation bone loss. So this tooth I suspect a crack on because the patient was in pain. The tooth was vital, symptomatic, lingering to cold testing, and tender to percussion. So one of the things that I would like to see, if the furcation area has any breakdown. If it has breakdown, that doesn't mean that 100% there's a crack. Could be periodontally related. But if I suspect a crack, and if there is a bone defect in the furcation area, especially if it's localized only on that tooth. If you look at the other side and there's intact furcation area, then I would start suspecting a crack that is running deep into the floor of the pulp chamber. And that's where I draw my line on saving teeth with deep cracks. If the crack crossed the pulp chamber floor, the prognosis here is poor to hopeless, and the tooth has to be removed. But how do you know? Well, I'll show you how do we know and how to make sure that the crack doesn't cross the pulp chamber floor. Excuse me. One of the things that we look at, as I mentioned, is the furcation bone if there's any bone loss in the furcation area. Now, this is the same tooth, tooth number 19, just right after I did some removal to the amalgam filling on the proximal area, and clear crack, very, very clear there. So that's how you feel, okay, yes, I made the right diagnosis. This tooth, we suspected a crack, and that's the evidence of it. So I try to take as many pictures when I do treatment. I have cameras attached to my microscope, so I can capture pictures for cases that I feel it's maybe a case that I would like to show the patient, or maybe we can use it for educational purposes to help each other, becoming better practitioners. This is the same tooth after removing all the silver filling, all the amalgam filling, and that's the video here. It shows that actually it has 1, 2, and 3 cracks. Let's rewind. Let's replay that one. 1, 2, and 3. So this tooth would be very challenging for our restorative colleague to diagnose if they would keep the amalgam filling intact, or if they would just go and remove a small part of it in doing root canals, for example. They just access through it. I would like on teeth like this to remove all the restoration. There's a good study showed that actually if you don't remove the restoration, especially if we're not talking about a full coverage restoration. Full coverage restoration is a different story. But a direct restoration like this, if you don't remove it all, you may miss 50% of cracks, recurrent decay, and other etiology that can lead to pulp pathosis. Now that's the same picture, the same tooth. We took a picture of it just to show how that crack is very extensive in this tooth. Now, I still don't know if this tooth is savable. I need to go into the pulp chamber and see how deep that root canal can go. So we went ahead and before that, let's talk about 3 different types of cracks, and let's see what kind of crack is the one we have on tooth number 19 we're discussing. So there is the partial crack on one proximal area. Most of the time, this crack stops like around or above the cemental enamel junction. There is the crack that runs mesiodistally and runs a little deeper sometimes, or sometimes it runs short, shallow, coronal to the cemental enamel junction. And there is the split tooth. The split tooth is where actually this whole piece moves, or that whole piece moves when you put any pressure on that crack itself. So split teeth, they are hopeless. A and B, they're treatable, but we're gonna go into more details about which one will save, which one will have questionable or poor prognosis. Now let's talk about this. This question I got a lot. Sometimes if you get a case like this one, like A, so a case like tooth number A, it has a crack. However, the nerve status is reversible pulpitis. What does reversible pulpitis mean? Means that when you apply cold to the tooth, the response will be, we call it hyper, exaggerated versus other teeth, but there's no lingering. The coldness will go up, and after 10 seconds, 15 seconds, it goes back to 0. So there's no lingering. What does the study show about those teeth, and what is the treatment modality that we should go as a first step? So here, there's a 6-year evaluation of cracked teeth diagnosed with reversible pulpitis, exactly like what we talked about. Treatment and prognosis. So the question most of my restorative colleague will ask is, what do you think, doc? Will I end up needing a root canal on my cracked tooth, or does the crown solve the problem completely? So when it comes, again, we're talking about reversible pulpitis, not symptomatic irreversible pulpitis. The tooth has inflammation that can be reversed. This study looked at 8,000 teeth, and they followed them. It's a good study by Krall and Rivera. They showed that those teeth with the partial cracks, let's call them, with reversible pulpitis, if you put a crown on them, a full coverage crown, there is a 20% chance that those teeth will end up needing a root canal within 6 months period. In my experience, it's not even 6 months. It's maybe within 2 to 3 months. Patient will become symptomatic. Most of them right after preparation, a week or two. I'll see a lot of teeth with temporary crowns with that situation. When I talk to my restorative colleagues, yes, it had a crack, but the tooth was not lingering. It's reversible pulpitis. We end up prepping the tooth, and the patient was in a lot of pain. And this is explaining this is very simple. When you vibrate a tooth to prep it, that is a lot of vibration you're putting on a tooth from the diamond burr, from all the other things we do to prep a tooth for a permanent crown. This may propagate. This may make that crack gets deeper to the point where it communicates with the pulp chamber, and then we have the whole cascade of pulp inflammation started and begins. So yes, it's so that is, I want you to put this study and remember it. It's very important to tell our patients when you see a crack, hey, there is a chance that you may need to see an endodontist, or maybe we need to do a root canal on that tooth. That would make the patient actually more prepared for the news to come if the tooth needs a root canal. And the worst thing you can do to a patient is surprise them with a root canal. So I would always just let them know that there is a possibility there. Now back to tooth number 19. So we talked about the whole presentation is case based. We're talking about, we take a case and we discuss things around it. So this is a video after opening the pulp chamber, cleaning the canals, and let's take a look at the pulp chamber floor. So that's the proximal area here. Looks like that was the mesial and that's the distal. But if you stop right, let's see, right here, that's where I'm concerned about. There is a crack running across the pulp chamber floor, and in this case there is no crack. And I see the crack here, stops there. Let's replay it again. So that's a crack running all the way to the orifice. Can it get deeper? Yes. Usually it leads to bone loss on CBCT or deep probing around that tooth if the crack gets way deeper. And we will have a diagram that we can use to help us determine which tooth to save and which tooth to maybe go the extraction path with it. One thing that I always talk about cracks is cracks are very challenging to know what's the periodontium status around them because they run mesiodistally. When the crack runs mesiodistally and you want to probe right around that crack, you can't because you cannot access it. It's between the two teeth. So what I recommend our restorative colleagues on a tooth like this, for example, even before you go ahead and maybe do a root canal on it, I would prep it. I would rough prep it, and that would open the proximal areas for you. And then you can directly probe the mesial and the distal and see if there is a drop. If there is a drop in the perioprobing, then this tooth is beyond saving. We're talking about poor prognosis. Now, this is the tooth after finishing the, what we did here is we finished the tooth. On a cracked teeth, I always recommend an immediate buildup because the tooth is completely compromised here. You don't want to take any more chances on that tooth. You know, it's very easy to have a split tooth if the patient bites on it while in temporary restoration. Also, what I always do on cracked teeth and sometimes on cracked teeth that they are not very cracked, but they are super symptomatic, severe pain, I would take that tooth a little bit out of occlusion. I don't want to put any forces on that tooth. So taking the tooth out of occlusion here, you can tell that this is more flat, and do a nice build out that hopefully can kind of like splint the tooth. The splinting eventually will come from the crown itself because that's where the crown hugs the tooth. But this is at least the least thing we can do until the patient will see their restorative colleagues, excuse me, for a full coverage restoration. Now, this is the diagram or the algorithm that we talked about. Helps you decide how to what path you go when you have a cracked tooth. So this is the same group, Krell and Rivera, that started the studies back in 2007. This is a follow-up study 10 years after. They follow the teeth and they try to see like what's the success rate on teeth with cracks based on multiple things, based on the probing depth, based on is there's a mesial versus distal marginal crack, is there is any periapical infection, like how far that progression in the pulp disease went. And based on those things, they came up with this diagram. So if the tooth has mesial or distal probing pocket more or equal to 5 millimeters, if it's yes, this is how much success we get, 41%. So it's very terrible success. So in my books, I stretch it to 6. If it's 6, then the tooth has to be removed. If there's no 5 or more probing, then do we have a distal marginal ridge crack? If yes, for example, for some reason, if there is no distal margin, let's take it this way. If there's no distal marginal crack, then the success is really high. That means only the mesial margin is cracked, and it seems like the distal margin has more catastrophic, I would say, outcomes, and most likely is just because the pattern of occlusion and the muscle of mastication and how the vector of forces applied to the tooth. If there is a distal marginal fracture, now they say, okay, is there a periapical lesion? CAP is chronic apical periodontitis. SAP is symptomatic apical periodontitis. By the way, those are the old definition. And you have the AAA, which is acute abscess. If there is any of those three, then if yes, then the success is really low. It's about 70%. If there's no periapical infection, let's say, if there's no periapical involvement, if we're just dealing with the nerve inflammation, then the success is pretty good, 84%. So if you remember our case, number 19, it was vital. The tooth had symptomatic irreversible pulpitis, but it has normal periapical diagnosis. So our success on our tooth is 84% success, which is, it's not, 90 or 95, but it's not terrible like 41 and 69. So I always tell my patient, look, with cracked teeth, there's a lot of uncertainty. What's the future going to hold for that tooth? The least thing we can do is, take you out of pain, remove that nerve, and put a crown on it. and have put you on a night guard and talk to you about stopping any parafunctional habits. Any habits of heavy occlusion, biting hard objects, all the things that we talked about regarding etiology. Now, this is a tooth that I put my hand on after extraction and I stained it. And the reason I put this tooth is to show you how cracks look under microscope and what's the directionality of it. Cracks, starts coronal and runs apically, so from the crown to the root. That is not the case with vertical root fracture, which we're going to have a full discussion about in the second half of this presentation. So if you notice here, this is the proximal. Actually, this is one of the proximal area. Seems like when they placed the crown, they had to do some adjustment. That's why this area looks like it has some burr marks on it. Cracks runs all the way to this level, which when cracks runs, actually they destroy the PDL around it, and they destroy the bone around it. So if I would probe this case, and if the free gingival margin is here, I'm talking about maybe 5 millimeter pocket here. Is that going to be the determining factor to this tooth? And that's why the tooth got extracted? We'll find out later, because this tooth actually has more for us to say. Now, when we talk about cracks in general, and we talked about the depth, probing depth, the status of pulp, if the pulp is in a reversible pulpitis and there's no deep probing, then the treatment modality is full coverage restoration, knowing that there's a 20% chance that you may end up needing a root canal. If the case has a reversible pulpitis, but less than 5 millimeter probing, that is exactly our case. Then we do RCT plus crown, root canal treatment plus crown. If the case has probing more than 5 millimeters, then we look at extraction, or if the crack runs across the pulp chamber. So if the pulp chamber floor involved, then we're also looking at extraction. Let's take a little bit of a mental break. We reached half of the presentation. We finished our discussion about cracks. I hope this part, the first part, kind of like helps you realize how cracks develop, how cracks affect the pulp status, at what treatment modalities, and how to decide on the modality of treatment of choice. Now let's talk about this. This is actually, so as I mentioned, I'm originally from Iraq. Iraq is the new name for Mesopotamia. Mesopotamia, if anyone has a little bit of passion for history, will know about Mesopotamia. It's the land between the two rivers, Euphrates and Tigris. It was the land where most of the early civilization, the cradle of civilization, had happened. And this is actually a monument you can find in Paris, in France, in the Louvre Museum. Goes back to Hammurabi. Hammurabi is the 6th king of the Babylonian kingdom. And this monument is the first, it's the oldest written law discovered yet, 4,000 years old. And one of the, I would say, one of the laws that it has, it's tooth for tooth and eye for eye. So teeth are very important even back in 4,000 years ago. If if two people had a fight and one of them had lost a tooth, then Hammurabi law will say, okay, the other person has to lose a tooth too, or the same for eye, which I think it's a little aggressive in the modern time now, where the punishment back then was a little bit harder, because Now we have more monetary compensation that people can, you know, submit, and that would maybe solve the problem between people. But this is something I wanted to share with you about where I come from and the history behind the area that I grew up in. Excuse me. Now, the second half of our presentation will be dedicated to vertical root fractures. Vertical root fractures are a complete entity. It's completely different than cracks. First of all, it's actually those cracks starts from the apex or the apical area of the root and runs coronally. When it runs coronally, it may reach to the crown or it may stop partially and just involve the middle 1/3 of the root structure. Also, it can be partial. When you look at it, it's maybe affecting only the buccal or the lingual, or it may affect both buccal and lingual. Another factor for vertical root fracture, another fact, sorry, is that it runs buccolingually. So in a buccolingual direction instead of mesiodistal direction. It also affects narrow roots like upper premolars, mesial root of a lower molar, or an MB root of an upper molar. Let's talk about the like where you find vertical root fractures often. Vertical fractures can happen mostly or mainly to endodontically treated teeth. Those are the teeth that been kind of like maybe put under stress before, and for that reason, they developed vertical root fracture. Excuse me. So there's a lot of hints that it can help us decide or diagnose what a vertical root fracture. One of them is the history of the tooth. Is that root canal being done many years ago? I would ask the patient. They said, oh yeah, doc, this is like, it's being done 15 years ago. And then I will follow up with, did that tooth ever give you any symptoms, any infection? They said no. It's all of a sudden we got some dull sensation, and I see that kind of like pimple and infection growing around it. So that tells me a lot about what I should expect from a tooth like this, especially if the root canal on a radiograph looks within the standard of care, to the length of the canal system, cleaned well, has a nice tapered in it. All those things will tell me, oh, maybe this is a vertical root fracture. Also, when there's a sinus tract, if the sinus tract is coronally located, means it's close to the crown margin of the tooth, I always suspect a vertical root fracture. Always. Now remember the tooth that we talked about earlier that has a crack. That's the same tooth. So now the tooth was extracted for a reason, because that tooth had a vertical root fracture. And when I stain the tooth, it shows very clear that the vertical root fracture starts apically, runs all the way down coronally, and stops here. That's very clear that this vertical root fracture pretty much went through the whole root structure and stops when the tooth structure has more integrity in it. Here, it's very thin, it's easy to split. That's why it happens. in the pericervical areas where all the forces of the tooth, where all the structure of the tooth lies. Now, we talked a lot about vertical roof fracture that has a J shape or a halo on a radiograph. So if you look at radiograph A, it looks like an okay looking, maybe fairly normal preapical radiograph. However, if you take a look at B, you will see that there's a vertical bone loss around this tooth, that's tooth number 20. What's the difference between this radiograph and A and B? The difference is that the radiograph A was taken from a straight cone X-ray beam versus B was taken with an angulated cone. And when you take a radiograph straight through the tooth structure, the radiolucency of the vertical roof fracture, as we talked about, it's buccolingually, so will be like here, will be overlapped the tooth structure, and that's why you don't see it on this one. However, when you take it in an angle, then you opened it up and you see it on a radiograph. So let's go back to basics. I'll tell you from looking at those two radiographs, the second radiograph was taken from a distally angulated shot, like the cone came from the distal directed to the mesial. Now, I want you to leave your comments, your answers in the comment section. This J shape, based on the angulation of the radiograph, what is the location of it? Is it buccally or is it lingually? And I'll leave it to you to take a look. Again, this is coming from the distal. So remember, I'll make it easy. The slob rule, okay? So is it buccally located or lingually located? Let's see. Let's have fun with those comments and just create some discussion. Okay. Now, again, there's a lot of talk about vertical roof fracture has a deep probing. Yes, it does have a deep probing. Can you find it all the time? Not necessarily. Sometimes it's hard to probe, especially if that vertical roof fracture is still newly developed, or if it's in a position where the perioprobe is not it's not easy for the perioprobe to navigate. So I recommend plastic perioprobes. It bends a little bit better, and then it can take the curvatures around the root and around the cervical area. Also, how to differentiate between a regular perioprobe from a periodontitis versus a vertical roof fracture perioprobing. First of all, periodontitis probing are wider in general, and they are mostly generalized. You can find them in other areas. Vertical roof fractures probing are very narrow, so we call it narrow, isolated, deep probing. It may need a little bit of pressure, actually, for you to be able to drop into the defect. So if you just put the perioprobe right there with no pressure, it may not take you anywhere. So one other thing you can use, so those are, the perioprobing helps in diagnosis, right? And knowing, is that a vertical fracture or is that a perio defect? Also, there is another method for diagnosis, which it's a little bit more, I would say, intensive. It's by raising a flap, and we call it exploratory surgery. You raise a flap and you directly look at that tooth. You can stain it and look for cracks. However, this procedure not always helpful, because what if you flapped it from the buccal, but the vertical fracture is from the lingual? So you have to what if the vertical fracture is from the lingual on a lower molar? So do you really want to risk flapping that area with the lingual nerve there, with all the other vital structures there? I think the more you see those cases, especially endodontists around around the world, they've seen their fair share of them, the more you'll feel comfortable diagnosing them. Also, one thing that I always recommend is if you suspect a vertical fracture, when you take that tooth, stain it and look at it. Just kind of like prove it to you and to your patient. Yes, we made the right diagnosis, because this diagnosis is definitely a blind diagnosis per se, and we are, as dentists, we don't like to do blind things. That's why a lot of restorative general dentists, they don't like to do root canals, because it's like, yeah, I cannot see it. We're just like blindly doing a procedure. They like to see what they are doing. So let's talk a little bit. Let's recap. Vertical fractures starts apically and run coronally. That's completely different than cracks. The directionality is buccolingually. Cracks are mesiodistally. Most endodontically treated teeth, so vertical fracture, you'll find it in mostly endodontically treated teeth. However, there's an exception to that. I've seen it in not regular, I mean non-endodontically treated teeth, where patients have habits of biting hard objects. There is also a study done in Asia, in East Asia, about people who bites betel nuts. Betel nuts are very, very strong, and they keep biting it every day, and end up actually stressing the roots and develop a vertical root fracture. You can find vertical fractures in maxillary premolars, mesial roots of mandibular molars, mesiobuccal roots of maxillary molars. So all the narrow roots. And also, as we talked about it develops sudden endodontic failure after many years of successful root canal in that particular tooth. Now let's talk about etiology. A lot of crossover between cracks and vertical fractures when it comes to etiology. Trauma is a big one. Excessive occlusal forces, grinding, clenching, that's another big one. Post material and design. The post we use is very, very important. If you use, for example, threaded posts are, they're very aggressive. They put a lot of internal stresses and develop cracks. If you prep the tooth, just like the tooth I showed you earlier with that lower molar that has huge distal post, that post is definitely a culprit for a reason for a crack. Long span bridges, teeth holding more than what they are designed to, holding forces that exceed their natural design, will develop vertical fracture. Aggressive dentin removal. So if you use a very large files with a aggressive taper, you will thin out that root structure and makes it more prone to vertical root fracture. Obturation techniques, a lot of talk about it. So let's start with lateral condensation. If you're still doing lateral condensation, the things that I want you to change is use finger spreader, for example, versus hand spreader. Use a night-eye spreaders versus stainless steel spreader. Do not put that much force. There's studies showing like how much force you can put, and you have to put, I would say, just, don't go with full force inside the tooth. That would create a crack. If you are a carrier-based obturation technique adapter, I would say personally, from what I saw, I see more cracks with carriers. I think it's just the fact that that carrier is made of metal or made of plastic, and it goes all the way and get wedged into the apex of the tooth. It creates an internal stress there. The technique that I use, and I think everyone can use it, we use the down pack technique. Pretty much, you go prep your canal system, put a tapered gutta percha cone with, I use bioceramics, so because it has great properties, it doesn't shrink. After that, I'll go with a heated plugger. That heated plugger will sear the gutta percha. And when I go with heated plugger, I go inside the canal system until I find a little resistance. And that's it. I don't push on it. Then I'll press for about 5 seconds with light pressure. Then I activate the heated plugger, spin out, and remove. And that will take the whole coronal part of the gutta percha out. Then I follow with a plugger, continuous pressure for about 5 seconds or 10. It depends on how much I think the space between the gutta percha and the canal walls. After that, I'll backfill it with a melted gutta percha, thermoplasticized gutta percha. Actually, I have a good picture and videos on the two devices that you can use to obturate passively with no pressure, so you prevent vertical root fractures. Those are from COXO. I actually tested those two devices. Is the one on the left hand is the heated plugger, and the one on the right hand is the backfill melted gutta percha. Both are well designed. It actually exceeded my expectation when I tested those two devices. I have a short video. We were talking about in a different seminar about a different case on how to obturate a specific case with an X configuration. It's more on the side of obturation and the tips and tricks in endodontics. Maybe on another day we can talk about other things other than cracks and vertical fractures. But let me show you this video. It tells you how to use this, because the heated plugger is a straightforward. This one, maybe some of our restorative colleagues would like to kind of like see a video on how to use it, how to activate it. So let's run this really quickly here. Yes. Okay, so we were talking about the case that we just discussed, and this is what you can also. I'm sorry. Okay, so we were talking about, X configuration of that canal system. This is the COXO C-fill. I've been actually testing this out. It's impressing me so far. The materials, the heavy duty, the size of it, it's really small. Comes with multiple needles here. It comes with a key to replace the needle if you want. Comes with a protection here, a cover to protect the patient lid from getting burned by the hot tip of the device. Also, COXO C-fill comes with a good amount of pellets. So pellets are pretty much the gutta percha that we're using here. You pull the plunger out. There is a space here that you load the pellet, then you push the plunger in, turn it on, and then you'll be ready to go ahead and use the backfill and fill that coronal space. If you have any questions about the backfill in general, the thermoplasticized gutta percha, just let me know. Shoot me an email or find me on Facebook and message me. Okay, so let's talk about how the CBCT is helping us in diagnosis when it comes to vertical root fracture. If you look at the periapical lesion here, you may say, okay, there is a darkness here, but you also can confirm it with the CT scan. It's very clear that there's a big radiolucency here. Is that radiolucency come from the mesial root or the distal root? It's very hard to tell. can be from both, but doesn't really matter at this point. It's at a tooth like this with a large infection, um, and it's not a terminal tooth, because you'll know why I said that in the next few slides. Um, I think the recommended treatment is to remove that tooth, replace it with an implant or a bridge. So CBCT is helping us a lot. Another case which is very interesting. This patient came to my office maybe last year, if I remember correctly. Severe pain, severe pain. She was like, "Oh my God, you cannot touch the tooth. It's very severe to palpation, to percussion." So I looked at the tooth. It seems like there's two root canals being done. There's a periapical lesion, a little bit more off-centered, I would say. So the lesion is not uh, centered around the apex. It looks like there is also a maybe transportation of the canal system. Instead of going to the apex, it seems like it went more to the distal. Then I said, okay, well, that tooth didn't give me any sign of vertical root fracture, by the way. Um, I thought it's just a periapical lesion. I took a CBCT, and you can see this dark area. This is very subtle, but it's very important. So that's why when you read CBCT, I would say stay in a dark room and take your time and read the CBCT. You'll find great findings. That is the bone loss developed uh, from the vertical root fracture. So most likely the vertical fracture runs in here. Look at, this is the axial. Look at the sagittal, how this bone loss runs vertically. It's very clear that there's something going on to make that bone loss runs vertically. So very, very informative. I am blessed and lucky that I'm practicing in the era where there's CBCT available. Also, where there's a microscope available, because those two things actually change the game of endodontics. Uh, I would imagine how our endodontist used to do it, 30 years ago, for example. So yes, this is the tooth actually after removing it, and you see how small that vertical root fracture is, and it's actually a partial vertical root fracture. It doesn't run all the way up. And if you look here, actually, this is where the transportation happened. And that's the area where the periapical lesion. So it's a clear sign of transportation here into a perforation. But that was not the reason why this tooth was extracted. Because this, we may go ahead and do an APIC on it and correct things. But vertical fracture, unfortunately, the science of dentistry is not there to save a tooth with vertical root fracture. So this tooth, I was able to put my hand on after extraction and scan it, and stain it and looked at it under microscope. So this very tiny crack can put the patient in tremendous pain. You cannot tell this patient was in tears. Now let's talk about this case. This is a little bit of a twist I'm gonna throw at you. First of all, this is a young patient, like fairly young. We're talking about maybe 22 years old, 23. Patient doesn't seem like it has any grinding or parafunctional habits, full cusps. However, when you look at tooth number 30, has an etiology of why this periapical lesion is developed. Big decay here, large decay to the pulp chamber. However, why this vertical root fracture develops? Why this vertical bone loss? Why it's there? It looks like a J shape to me. Is that a crack? Is that a vertical root fracture tooth? Can we say, okay, let's take that tooth out? At that time, I didn't feel comfortable saying that, because there's multiple reasons. First of all, the tooth didn't have a root canal. Second, it's a young patient, so the tooth didn't go through the stress, the cyclic fatigue, I would say. Third, there's a big etiology going on, large decay. So I decided to go ahead and treat that patient. And the patient, the CBCT, actually, when I took the CBCT, I was even more confused because it looks like a vertical root fracture, looks like exactly a vertical root fracture. So that was a very interesting case. But when I put everything together, it didn't make sense that this tooth has a vertical root fracture. So I decided to treat the patient after, consenting with the patient, decided to do a root canal, knowing that there is a possibility that this tooth may have a vertical root fracture, and the patient was aware. And this is exactly 6 months, not even a year, 6 months after the treatment. Look how nice that bone healing. Look how nice the fill is. That was like a proof to us that not every J shape looking lesion can be a vertical root fracture. You have to put everything together to reach to that diagnosis. And always remember, there's a reason why this tooth had that J or vertical bone loss. Let me explain the reason behind the bone loss running along the root structure. Young teeth, young patient, they have dentin that they are very porous. The dentin of that tooth is very porous. It's like a sponge. When you have a necrotic tooth, let's go back here, a necrotic tooth, that this whole area, its whole canal system is filled with bacteria. There's a lot of communication between the canal system and the outer surface of the tooth and to the periodontium and the supporting structure. So this bacteria leaked. The bacteria leaked from everywhere in that canal, leading to a vertical bone loss looking that can be confused with a vertical root fracture. So yes, this kind of like throw a lot of the things that you thought, oh yes, I got it down. If it has this, it's a vertical fracture. But I want you to pay attention to young patients with no root canal, with a clear etiology. Also, I've seen another example or a different scenario. Let's put it this way. It's a different scenario where a tooth that has a deep pocket, that it is kind of like looking like a vertical root fracture. It didn't have a root canal. It's a tooth that non-endodontically treated, but has a deep pocket. This scenario usually happens on the lower second molars. The lower second molars, they have a very thick buccal bone, to the buccal side of it. If there's a periapical lesion underneath the tooth, that lesion will have no path, or will have no chance to create a path through that thick buccal bone. So what this periapical lesion will do will create a path along the root structure, because that's the path of the least resistant, and create a venting mechanism for the discharge of the periapical lesion. And that is where, when you probe, you find it deep probing take you all the way to the apex. So that's another scenario where you would think there's a vertical root fracture, but it's actually not. So in general, if the tooth didn't have a root canal treatment and it has a clear etiology, I would go with an endodontic treatment first. Sometimes it'll work out, sometimes not, but you have to give the option to the patient. Now let's go back here. This is what, okay. Now this is another case. So this case is completely different, because I wanted to restore your faith in what we learned today. This tooth the patient is 85 years old. That tooth was endodontically treated, and the patient came with pain and periapical lesion here. I said, okay, it looks like a vertical fracture to me. It has all the factors to make me believe that this is a vertical root fracture. I told the patient, well, you need to remove that tooth. One of the options is to remove the tooth and replace it with an implant. She told me, I'm not doing an implant, and I want this tooth to chew on because I have no distal tooth to it. So here where you can think a little bit out of the box and do something, we call it a root resection or hemisection. It's actually hemisection more than a root resection. Root resection is you cut it here. Hemisection, you cut through. So what you can do is cut this part away. Just cut the fracture root away. And this is a perfect tooth to do so because multiple reasons. One, you wanted to do this to a distal a portion of the tooth. You don't want to have another tooth here and you cut this and you create a small gap that, it's not easy to clean maybe. Also, this tooth is a very good candidate because we're talking about a root structure that has a clear space between where I can put my burr and cut through without damaging this root. And also without creating a lip. Sometimes you create a lip here, which bacteria can hide, and that would lead to breakdown of the furcation area and lead down to further complications. So this is the tooth, deep probing about 12 millimeters. That's what we did. First of all, we sectioned the crown. It's a porcelain PFM crown. We informed the patient that this crown may fracture and you may be looking at a new crown. She said, I don't want to spend any money. She is in a situation where she just wanted to kick the can down the road. That's exactly what she wanted to do. Then you go ahead and section the whole tooth and then remove the root. That's actually this part through a mirror. You can see it's an old PFM. It's actually gold base or noble metal base fused to porcelain. That is our access filling. That's our orifice barrier. It's a different color orifice barrier. And this is how we finished the surgical extraction of the root tip. We put a membrane here, collagen membrane, and we suture it. And that's how it looks after resection. So very clean cut here. There's no lip, very important. We also, by the way, we retreated this root just to make sure that we're not missing anything. And the patient has a third premolar now that she can use and take advantage of. So it's a little outside the box, but when you have a case that everything lines up, I would take advantage of this treatment modality. It's a great option. Okay, this is the end of our seminar. Thank you so much. I would love to answer questions. This is all about you guys having questions, and I'll be happy to answer those questions and have some discussions around them. Bruce, is all yours now.
Okay. There are some questions coming up. Dr. Basile, would you please answer the following questions raised by the audience? Take some time. Thanks a lot for taking your precious time to giving us so exciting lectures. Now, please answer the questions now, and pick up the best one a moment later.
Okay, so the first question is by Trashithri Shetty. Even after treating endodontically, are there chances of vertical fracture of teeth in crack cases if the crack is restricted to coronally? A great question. Absolutely. So that's, you remember what I talked to when we talked about cracked teeth has a lot of uncertainty because we don't know what's the future of that crack. Just like the windshield crack, it can get deeper, longer, propagate. It's the same thing with coronal crack. Even if you do a root canal on it, that crack today is restricted to the coronal structure and you put a crown on it, but tomorrow it may be completely different. We don't know. So if I understand your uh, question correctly, yes, even after you do an endo on a tooth that has a crack, there is a chance that the tooth may have a vertical root fracture or that this same crack can propagate and get deeper. Okay, a second question is overpreparation of canals is a cause for vertical fracture endodontically? It's one of the causes. So one of the etiology for vertical root fractures is the aggressiveness of um, root canal preparation. There's a study, very nice study. They put pressure on root tips, and they did something they call it finite elements. It shows you where the stresses goes around that too, around the root structure when you apply forces on it, and it gives you a different color. Red means really strong stresses goes on that. And most of the stresses actually happens at the coronal part of the root structure, where that CEJ, just under the CEJ, we call it the pericervical area. All the forces happens there. And guess what? Most of the endophiles we have in the market nowadays, they have aggressive taper, very aggressive, especially coronally. So you're taking away the most valuable part of the tooth structure and make it weaker. So yes, to your question, absolutely. Okay, all the question was asked by the same person, Dr. Shetty. Okay, no problem. Now there's another question asked by Shilpa Panzadi. If fracture extends mesiodistally, we have to go for extraction only, or we can save the tooth. Okay, this is, so your question is, it's very, the answer to it is very deep because it pretty much covers the whole first part of the presentation. But I want to make it, I'll make it short. If the mesiodistal crack runs through the pulp chamber floor, the base of the floor, that's an extraction. If the crack has a deep pocket, more than 5 or 6 millimeter, that's an extraction. Other than this, I would attempt saving the tooth. Okay, that's question asked by Oras Haddad. Can traumatic occlusion cause vertical root fracture, like an interior open bite? Absolutely. Great question, because it's more related to occlusion, which we think we know about occlusion, but it's a very large topic. Anterior open bite, when I say anterior open bite, I always go back and look at the posterior teeth. And 90% of the time you'll find cracks, enamel crazes, stresses, you find tori, a lot of pressure puts on those because all the muscles of mastication forces goes to those 2 or 3 back teeth, posterior teeth. So to answer your question is definitely. Okay. Now let's use the best question. Is overpreparation of canals is a cause of, okay, all question. I would choose the first question.
You have
By
finalized.
Dr. Shetty.
First question is the best question.
Yes, by Dr. Shetty. Even
Okay.
after treating endodontically, are there chances of vertical root fracture of tooth in crack cases if the crack is restricted to coronally? Yes, I think that's a good question because it shows me that the person who asked this question understood the difference between the cracks coronally and the vertical root fractures, which are two different entities.
Okay, evidently, we have seen the enthusiastic audience participating in your lecture and raised some questions. Thanks a lot again for your nice sharing. And now,
Absolutely, my pleasure.
Okay, next come we will come to the lucky lottery time. Let's see who will be the lucky one to get our special gift. And this time, the special gift is our Stu and 3 sets of SC Pro Endophile. Now, I'll count down. Now let's begin. 3, 2, 1, start. Well,
Demand Nath.
to you now, my friend. The lucky one has come out. We will contact you after the webinar. For those who
Congratulations to both of you.
Prize, don't worry. We'll have more events with abundant prizes in the future. You are always welcome to participate. Okay, thank you again, Dr. Basil Shackley, and thank all those who have participated in our live course. Don't forget to fill in form for the certificate. That's all for today. See you next time.
Thank you so much, Bruce. Thank you, everyone, for being great audience. I enjoyed, talking to all of you. If you have any questions, please find me on Facebook under Basil Shackley. Text me, message me over there. I'll be happy to answer any questions, or if you have any comments, please let me know. And hope to see you soon again on a different topic in a different webinar.
Okay, see you again. Bye-bye.
Thank you.